So let's start this webinar. So this is the EMPHNET WEBi series, webinar 50, and addressing making new vaccines work, strategies for introduction, delivery, and demand using RSV as an example. And my name is Ziad Memish. I'm a professor of infectious disease at the College of Medicine at Al Faisal University, and also work at KS Relief as an advisor to Supervisor General. So what we will be doing today is addressing a virus that is extremely important for adults and also for children and people who are immunocompromised. This is the RSV virus. This is a virus that causes significant morbidity and mortality across the globe. We have been fortunate over the last few years with the development of new vaccine and also new monoclonal antibodies that has shown extreme effectiveness in reducing morbidity and mortality. And there's plenty of data that has documented this improved morbidity and mortality, including some recent publications in the New England Journal of Medicine that came out last month. So what we will do in this session is try to talk about the global epidemiology of RSV, and then look at the regional data, especially looking at the Eastern Mediterranean region, and then try to discuss implementation strategies. Every time there's a new vaccine or the new initiative to address public health, there's a lot of work that needs to be done to sort of introduce that product into public health, requiring study, review, integration into the currently applied vaccination program in the country. So the objective of this webinar is to present the global overview of burden of disease of RSV on a global level, and then highlight the epidemiology of RSV in our region, in the Eastern Mediterranean region, and then discuss RSV effectiveness, safety, and implementation strategies, along with the challenges that countries would face in introducing this new vaccine. We will also showcase country examples for early adopters so that we can provide practical lessons to countries to use and support them in introducing the vaccine and the strategy in their own countries, and then promote knowledge exchange and have opportunity for questions and answers so that we can answer any queries that you might have over the next hour and a half. So with that introduction, let me introduce our esteemed faculty, and we will start with the global epidemiology of RSV, and we are honored to have Dr. Francisco Nogoreda. He's a Spanish-trained field epidemiologist with over 20 years of experience in the field, especially in disease surveillance, outbreak prevention and control, and also immunization. He has worked in the National Center for Epidemiology in Spain and also at the Public Health Institute in France. Since 2014, has joined WHO in Geneva, supporting implementation and coordination of vaccination campaigns and outbreak response activities. And in 2020, he has been working at WHO Regional Office in Amro, and he's the focal point for influenza, COVID, and RSV, and hence he'll be providing us with technical information about the global epidemiology of the disease. So without further ado, we will introduce Dr. Francisco to give us the global epidemiology presentation.
Thank you very much, Professor. Thank you for the introduction, and thank you, EMPHNET, for the invitation. This is my pleasure to be today in this webinar and discuss about these new prevention strategies against RSV. I will focus on prevention strategies and as in more particular the experience that we had in the American region. It is one of the first regions globally to introduce these products. Now, I will focus my presentation in three main components. The Pan American Health Organization or Region of the Americas recommendations for the use of the maternal vaccine and use of long-acting monoclonal antibody nirsevimab. Then, how was the introduction process in the Americas of these products? And finally, the considerations for introduction and the activities post-introduction. So based on the surveillance data, as you can see in this graph, most of the hospitalizations occur under 5 years old, in children and under 5 years old. So this is happening globally, but we also provide this information through the surveillance system in the Americas. So children under 5 are particularly at risk of severe disease. Currently, we have several products available and licensed for the prevention of RSV disease in infants. We have the maternal vaccine, which is delivered to the pregnant women, and the protection to infants happens through the uh, transplacental passing of antibodies from the mother to the newborn. Then we have two long-acting monoclonal antibodies that are delivered to the newborns. This is nirsevimab and the most recently clesrovimab, recently approved in the United States a couple of months ago. And then we have a short-acting monoclonal antibody, palivizumab, that was approved more than 20 years ago. Then we also have a couple of vaccines, 3 vaccines available to prevent disease in individuals with comorbidities and other adults. We will focus on the prevention of RSV disease in infants, since I already indicated is the most affected age group. So how is the recommendations timeline globally and in particular in the American region? In November 2023, the Pan American Health Organization or the American region for the WHO Technical Advisory Group on Immunizations provided the first recommendations. That was the first region globally to provide recommendations about the RSV maternal vaccine. Then in September 2024, the WHO Strategic Advisory Group of experts on immunization provided as well. They met and they provided preliminary recommendations to prevent disease in infants. And then in February 2025, the PAHO, the Pan American Health Organization Strategic Advisory Group, met for the second time and provided an updated recommendations. And finally, more recently, in May 2025, the WHO published a position paper for the RSV prevention in infants. So, sorry. Can you see my screen?
Yes, we can.
Yeah? Okay. Because I don't see my screen now. Sorry
Now we
about
can see it, but if you can forward to the next slide and proceed.
Okay, can you all right, I see. So all right. So the Pan American Health Organization Strategic Advisory Group provided 4 main recommendations. So countries should introduce either the maternal vaccine for pregnant women or the long-acting monoclonal antibodies for newborns, or both, to reduce morbidity and mortality associated with RSV disease. For those countries opting to use the RSV maternal vaccine as a primary strategy, the PAHO Strategic Advisory Group recommends that it's best given to pregnant women in the 3rd trimester, between the 32 and the 36 weeks of gestation. And countries should determine the optimal timing of administration based on the epidemiology of the country. For those countries opting to use nirsevimab, or the long-acting monoclonal antibodies, as a primary strategy, may consider administering to all infants, to all newborns at birth or soon thereafter, or only for those newborns most at risk. So this is a country decision. And finally, countries also may opt for use a mixed strategy, a hybrid strategy, using the maternal vaccine for pregnant women, but also providing the nirsevimab, the long-acting monoclonal antibodies, to those children that were not protected through maternal vaccination. So how was the introduction of these products in the Americas, in the American region? So in October 2023, we had two countries in the Americas, the United States and Canada. These two countries introduced the both maternal vaccine and the long-acting monoclonal antibody nirsevimab. But then a year later, in 2024, March 2024, two countries introduced these products. Argentina introduced the maternal vaccine, and Chile introduced the nirsevimab as a strategy for prevention of RSV in infants. Then, a bit later, in August 2024, Uruguay introduced the maternal vaccine. And this year, since March to December 2025, more countries, Brazil, Colombia, Costa Rica, Cuba, El Salvador, Panama, introduced maternal vaccine, and Paraguay introduced nirsevimab. So now this created a lot of media attention. As you can see, these are press releases from Ministry of Health, press notes indicating that these products will be available for the prevention of RSV in infants, and it created a lot of media attention. So up to December 2025, we have 12 countries in total in the Americas. We have 8 countries in blue. They're using only maternal vaccine as a primary prevention strategy. These are colored in blue. Then we have 2 countries that are using only nirsevimab as a primary strategy. These are Chile and Paraguay. And then we have 2 more countries. They're using both strategies, mixed strategy using maternal vaccine, but also the monoclonal antibody. And these are United States and Canada. I have to say that these countries probably will introduce a mixed strategy in the coming years. So the countries that are opting for using the maternal vaccine, they are also considering the introduction of long-acting monoclonal antibody as a mixed strategy. This table, this table shows how is the strategies for prevention of RSV in the Americas. So you can see the most of the countries are using the maternal vaccine, are administering the vaccine between the week 32 to 36, except Colombia is using the week 28 to week 36, and Brazil from 10 to 28 weeks of gestation onwards. And as you can see here, there is an S and a Y. It means that S is a seasonal strategy and Y it's a year-round strategy. So depending on the epidemiological patterns and seasonality, countries are vaccinating or administrating these products in a seasonal way or year-round strategy. Depends on the epidemiology, as I mentioned. And same for the nirsevimab. So the countries they are targeting children less than 8 months, and other countries are targeting less than 5 months, and others less than 3 months. So it depends on the country, the strategy, how it's adopted. As I mentioned before, the nirsevimab is not introduced yet, but it will probably introduced in the coming years as a hybrid or mixed strategy, complementing the RSV maternal vaccine. Okay, so what are the main considerations for implementation? So as I mentioned, it's very critical to understand the epidemiology of the disease in the country to determine what is the most optimal timing for vaccination. So if you have in your country a seasonal pattern, the most appropriate and most cost-effective will be a seasonal administration. But if you have countries in tropical and subtropical areas that have more year-round transmission with several peaks during the year, a year-round strategy could be also considered. It's important that countries introducing these products establish a safety monitoring among vaccinated pregnant individuals for the maternal vaccine and also for newborns. So active monitoring of safety and pharmacovigilance is also very important. But setting this surveillance system should not delay the introduction of these products. Then the RSV prevention or immunization it has to be integrated in the existing health system. It has not be separate from the existing EPI program. So RSV vaccine can be administered during routine prenatal contacts and administered with other recommended vaccines during pregnancy. And the long-acting monoclonal antibodies that are administered to newborns can be administered at birth or before being discharged, or as a routine immunization visits. Uh, in infants that are entering in the first RSV season. Countries should evaluate the feasibility in terms of financing of introducing these products to ensure sustainability of the EPI program. So there are other routine immunization that um, cannot be delayed or be in danger because of introducing these products. Have to remind that these products are not cheap, are costly, and so it requires a major investment. So the introduction of these products requires a more major investment, which must not detract from implementation of other essential childhood and adult vaccines. Once the country has introduced these products, it's important that country conduct some activities post-introduction. First, monitoring coverage and report to the EIJRF to assess the acceptance of these products among pregnant women, caregivers, and healthcare workers. Monitor and estimate the vaccine effectiveness. Also evaluate the impact in terms of averted burden of these interventions, vaccine safety monitoring, and post-introduction evaluation. Sorry. So these are some of examples. This is Argentina. The coverage for the 2024, the first year of introduction was 62.5. This is a protocol developed by WHO to monitor the vaccine acceptance. It's called the behavioral and social drivers, and includes as well the assessment for RSV with influenza and COVID. We implemented this study in Argentina among pregnant women. And we also monitor vaccine effectiveness. And we had a regional network in the Americas. It's called REBELAC, and it produced yearly estimates for vaccine effectiveness for influenza, for COVID, and now more recently for RSV. And here we have some of the examples of the vaccine effectiveness studies conducted in Argentina. The vaccine effectiveness against hospitalization, as you can see, there are 4 studies available. They vary from 65 to around 80% vaccine effectiveness against hospitalization and between 70 and 85, 90 against ICU admission. We also provide the support to Chile for monitoring the impact evaluation and to assess the number of hospitalizations averted or prevented. And this is a study that has been recently published in Lancet. And finally, it's also very important to conduct a post-introduction evaluation, similar as we did for COVID and for influenza. These evaluations evaluate the impact of the introduction in the immunization program, identify and document the main strengths and challenges, and help to recommend corrective actions. It's also important for all the countries because it's sharing lessons and has to be conducted between 6 months and 18 months post-introduction. We have planned two post-introduction evaluations, one in Uruguay, March 2026, and one in Argentina in May. I want to finish with these materials and resources we developed, and they are available from the PAHO website. Is annex to the maternal immunization and neonatal field guide, and it's available. And we also had a webinar about the maternal vaccination last year. So that's all of my slides, and I stop here. And if you have any comment or questions, happy to answer. Thank you very much.
Thank you very much, Dr. Francisco, for this elaborate and comprehensive presentation. And also thank you for your leadership in the PAHO region in implementing this important vaccination program on the regional level. I know that you have to leave for another commitment. So if there are any questions from the audience, we can, Dr. Francisco has 5 minutes to respond to questions. But while people think about their question, maybe I can quickly ask you a question about the challenges. Can you just give us some examples of the key challenges faced in the PAHO region as far as implementing this program over the last few years?
Thank you, Professor, for this very important question. I think the main challenge that countries are facing at the moment is the high cost of these products. At PAHO region, the American region, we have a mechanism to procure this vaccine, maternal vaccine, through a common procurement process. It's called a revolving fund. And the cost of this vaccine is $49. And it's a very low price compared to the other countries they are paying. Despite this low price, it's still a high price for just single vaccine. Just to remind you that this RSV maternal vaccine cost is more than the whole routine child immunization schedule. So all the routine immunizations for kids, for children, are less costly than just one single vaccine. So the main challenge is to countries for the investment, but is still cost effective because it's a very effective intervention that reduces hospitalization of newborns that are very costly as well. So this is the main challenge. Other challenges are the short window for vaccination pregnant women. We have only 4 weeks, 32 to 36 weeks of gestation. So this is also very challenging for countries to vaccinate pregnant women in this short window of eligibility. And then for the long-acting monoclonal antibodies, the cost is even higher as well. Only 2 countries are using this monoclonal antibody. And another challenge is to monitor coverage. We are vaccinating pregnant women, but we are preventing disease in children. So you have to have interoperability systems between the clinical data from hospitals and for children, but also asking the maternal vaccination of the mothers. I think they are the main challenges. Thank you. Sorry, Professor, you are muted.
Can you hear me now?
Yes.
Hello? Okay,
Yes.
sorry. So there are 3 questions in the questions and answer section, and I will summarize them in one question. I think the audience are saying that most of the data is coming from middle income and high income countries, and And is the experience of PAHO applicable to countries which are having conflict, displacement, and weak health system, especially when the priorities are different? And I guess this is probably applicable to our Eastern Mediterranean region. So maybe you can try to address these comments in a short response. Thank you.
Thank you. We don't have much experience of using these products in low income countries and in countries or settings with conflicts and humanitarian crisis. Obviously, there are other priorities in these settings, and we don't have much information. These products have been tested mostly in upper middle income countries and high income countries. So, and considering the cost of these products, it seems to be difficult for low income countries to have access to this. But still, there is a room for opportunity to get these vaccines, and the Belinda and Bill Gates Foundation agreed to produce and fund a multi-vial vaccine who will be decrease the cost of these vaccines. So in the coming years, we will probably see more accessible products in terms of cost. And so countries, low-income countries and low-middle-income countries can have access. But we don't have much data on effectiveness in low-income countries. It's a good question. Thank you.
Thank you. And the last quick question is, why do we have to administer the monoclonal antibodies and the vaccine together?
Thank you. That's a good question, but we don't have to administer both products in the same pair infant mother. You administer either the vaccine to the mother or the monoclonal antibody to the newborn, but not both. Only in a situation where the mother was vaccinated and the delivery was before 14 days after vaccination, you can administer the long-acting monoclonal antibody because you don't consider this newborn as protected because there was no time, sufficient time for the transplacental transfer of antibodies from mother to newborn. Otherwise, there is no indication of administering both products in the same pair, infant and mother.
Thank you very much. We appreciate your time and your explicit presentation, and we thank you for giving us this impressive presentation. Thank you very much, and we'll move on to the next presenter. So now it's my honor to introduce the next presenter, who is Dr. Muhammad Amran Nisar. Dr. Muhammad Amran Nisar is an associate professor and vice chair of the Department of Pediatrics and Child Health at Aga Khan University Medical College, Pakistan. He holds PhD and extensive training in pediatrics and neonatal medicine. He has authored more than 160 peer-reviewed publications with his research focused on neonatal and infant health, infectious disease, and also epidemiological studies in low and middle income countries. His work has contributed significantly to global efforts aligned with the UN SDGs, particularly in promoting child health, reducing inequalities, and improving maternal and newborn outcomes. He brings expertise in cohort studies, infection pharmacology, and global health. And basically, his presentation will highlight the importance of administering the RSV vaccine to countries in low income. So with that, let's move on to the recorded presentation.
Assalamu alaikum, Masa al Khair, and good afternoon. This is Dr. Imran Nisar. I'm an associate professor and vice chair for research at the Department of Pediatrics and Child Health at Aga Khan University in Pakistan. And today I'm going to focus on why RSV matters, what is the latest evidence about prevention, and how this translates into policy decisions, particularly around maternal immunization. Despite major progress, nearly half of the all under 5 deaths still occur in neonatal period, and infections account for a large share. Maternal immunization is uniquely powerful because it protects infants from birth precisely when their risk is highest and routine infant vaccines have not yet taken effect. The key message here is that maternal immunization is not a new concept. It's an established platform that RSV can build upon. Uh, this slide shows the annual global burden of RSV, and we can see here that RSV is responsible for more than 33 million episodes of severe respiratory infections in children under 5 years of age annually, and it is leading cause of hospitalization, leading to around 3.6 million hospitalizations every year and more than 100,000 deaths annually. This figure from the Perch study shows the etiology of severe pneumonia across 7 countries in Africa is responsible for RSV stands out as the leading cause of severe respiratory infection for about 1/3 under 5 years of age. This is based on standardized diagnostics hospitalization leading to not assumptions. From programmatic perspective, this tells us that RSV prevention more than the potential to
Is there any way we can fix the echo, please?
Hospitalizations in young children. When we look specifically at neonates in South Asia, in the ANISA study, RSV again appears among the top causes of serious community-acquired infections. This challenges us a perception that RSV is only a problem later in infancy. The implication is important. Interventions need to act very early, which is exactly where maternal immunization has an advantage. These data again highlight an often missed issue. RSV mortality is frequently undermeasured. Community mortality studies like these have shown RSV detected in infant deaths across multiple LMIC settings. When this hidden burden is accounted for, RSV associated mortality in infants under 6 months may reach up to 200,000 deaths annually. And hospital-based surveillance alone significantly underestimates this impact. The RSV prevention landscape has changed rapidly. We now have 2 effective prevention approaches, maternal RSV vaccine and long-acting monoclonal antibodies. Countries are no longer asking whether RSV prevention is possible, but rather which strategy fits best their health system and financing context. RSV Pre-F was developed to address a clear unmet need preventing severe RSV disease in early infancy. In the METISI phase 3 trial, maternal vaccination showed 82% efficacy against severe RSV disease in the first 3 months, around 70% protection through 6 months of age, and protection was seen against both RSV and B, and also against the less severe disease, important for overall health system impact. Safety in pregnancy is critical for policy decisions. In METISI, adverse events were comparable between vaccine and placebo groups, including serious adverse events in infants. Importantly, rates of prematurity and extreme prematurity were similar across groups and consistent across countries. This provides strong reassurance for national immunization technical advisory groups. There was a slight numerical imbalance that was seen in the preterm birth rates in the placebo and the vaccination arm. However, this difference was not statistically significant, and the difference was more pronounced in Argentina and South Africa, and with the only South Africa showing statistically significant results. So these are the overall efficacy results from the primary outcomes. We already briefly touched upon this. So 82% vaccine efficacy for RSV positive severe medically attended LRTI and in the first 3 months of life, and 70% in the first 6 months of life. As of mid-2025, more than 60 countries have approved RSV pre-F for use in pregnancy. This includes countries across income levels and regions, reflecting growing confidence in both the evidence base and programmatic feasibility. RSV maternal vaccination is rapidly becoming part of the global immunization landscape. WHO SAGE, or the Strategic Advisory Group of Experts on Immunization, now recommends that all countries introduce RSV prevention products for infants. Importantly, WHO emphasizes context-specific decision-making, taking into account cost and cost-effectiveness, financing and supply, expected coverage and feasibility within existing systems. This allows countries flexibility rather than a one-size-fits-all approach. So WHO guidance also addresses seasonality, and for countries deciding to use the maternal vaccine, it recommends giving a single dose in the 3rd trimester of pregnancy, starting at 28 weeks in gestation in most settings, but could be earlier in some places. No upper gestational limit for vaccination except for pregnant people in active labor. It can be co-administered with vaccines normally given at the same time. And at the moment, there is limited data on if the vaccines need to be given in the subsequent pregnancies or not. So WHO, this vaccine has already been WHO pre-qualified, which is a critical step for introduction in LMIC settings. It ensures that vaccines procured by UNICEF and supported by Gavi meet standards for quality, safety, efficacy, and programmatic sustainability. Without WHO pre-qualification, global procurement and financings are many times not possible. So one of the early adapter countries, Argentina, provides valuable real-world effectiveness evidence using a test-negative control design. The Bernie study showed that maternal RSV vaccination reduced RSV-associated hospitalization by around 70 to 80%, and severe RSV disease consistently across analysis. These findings closely mirror the Matisi trial, strengthening confidence beyond control settings. Since then, many real-world effectiveness studies have reported similar effectiveness estimates, and the evidence base for in the real-world setting is building up. So, in summary, the Matisi phase 3 trial RSV pre-F maternal vaccination showed 82.4% efficacy in preventing severe RSV associated LRTI in infants from birth through 3 months of age, and 70% from birth through 6 months. Studies of real-world effectiveness showed vaccine effectiveness was again between 70 to 79%, between 70 to 79%. And maternal immunization with RSV pre-F has an acceptable safety profile and has been studied in clinical trials and post-marketing studies. So far, the vaccine has been implemented globally in more than 1.8 million doses to pregnant individuals to protect infants from RSV infection. So a little about our efforts towards introducing or expanding the maternal immunization platform in Pakistan. So in So as part of the Maternal Immunization Readiness Network in Asia and Africa consortium, which comprises of 7 African and 2 Asian countries, we are taken up on this endeavor to do this work across 5 work packages, which includes estimation of the disease burden within the country, and using systematic reviews and compiling data from the national surveillance. Showing evidence on the cost effectiveness and the budget impact analysis and the cost of introduction of the vaccines, looking at the health systems and the facility readiness for the introduction of this new maternal vaccine, and again looking at the demand aspects of the vaccine, and eventually developing a national level strategy for the introduction of this new vaccine as part of the Gavi's vaccine investment strategy 6.0. And across the spectrum, engaging relevant stakeholders and building the momentum for the introduction of this vaccine. At the same time, we are also doing a real-world study to evaluate the effectiveness of maternal RSV vaccination on infants hospitalization in one of the districts in Sindh. This is a test negative case control study design, and the research question that we're trying to answer is that what is the effectiveness of the maternal RSV vaccine in preventing RSV confirmed severe lower respiratory tract infections in infants under 6 months in a real world setting in Sindh, Pakistan. This piece of work has 3 streams. Stream 1 is about maternal RSV vaccine readiness, rollout, and demand generation in the identified districts, and in parallel developing a hospital based sentinel surveillance systems for RSV, and real world vaccine effectiveness evaluation using a test negative case control design. And this is how the case control study design will look like. So children under 6 months of age with a predefined case definition present to district or taluka level hospital, where they are tested for RSV, and those who are positive are classified as cases, those who negative are classified as controls. And then in both cases and controls, then we elicit the history for maternal vaccination in the incident pregnancy, whether the woman was vaccinated when she was pregnant with that child. So this study is expected to start in by Q2 of 2026, and hopefully we'll have some real world data before the introduction of the vaccine into the to guide the introduction of the vaccine into the national immunization program in the next 18 months. Thank you very much for your attention, and I'm happy to answer any questions towards the end.
Thank you. I think Dr. Imran has committed to joining us at the question and answer section at 6 o'clock. So I think we will move ahead to the next presentation, which is by Dr. Azzuddin Mahsini. Dr. Azzuddin Mahsini is known to a lot of us. He's a very dear friend. We've known each other for more than 16 years. He's a senior public health international expert with more than 30 years of experience in vaccine and immunization at national, regional, and global level. He served as the national EPI manager in Tunis for 8 years then joined WHO EMRO, where he worked for 16 years in several senior positions, including the regional advisor for vaccine and immunization, regional coordinator for polio eradication, regional coordinator for disease control, elimination, and eradication, and head of WHO EMRO Communicable Disease Department. In 2016, Dr. Mohseni joined EMPHNET, where he served for 4 years as a senior technical advisor. And in June 2020, he returned to Tunisia and worked for 3 years with the European Union as principal technical expert. Dr. Mohseni currently is working as a freelance expert and is member of several technical groups. The key one is he's chairing the WHO Technical Advisory Group on Market Information for Vaccine Access, and also chair of the RITAG on the regional level, among many other committees. And we look forward to hearing his talk about vaccine implementation, talking about effectiveness, safety, and introduction strategies for the region. Dr. Mohseni, please proceed.
Thank you, Dr. Zayed. Thank you to EMPHNET colleagues for giving me this opportunity to talk about this very important topic and this very important vaccine. I think all of us, we know in the region now that the region is witnessing from time to time epidemics of bronchiolitis in several countries, and we have seen some of the countries investigating and try really to understand what is happening. But definitely those that have done it, they know very well that RSV is responsible for at least 25 to 30% of these cases every year. So what I'm trying just to say, I mean, next please. So I will start with a very brief introduction of the situation at global level, perhaps, but to go more in the region and different WHO, but in particular in our region, and to end with some thoughts about the readiness and challenges. Next, please. So first, I mean, I think all of you know that this is a very, very important problem, health problem in the region, actually. And this is perhaps the biggest risk for the youngest children in the region. RSV is so widespread in actually the global level that almost all children contract the virus before the 2 years of age. It can really cause very severe disease and important complications, including bronchiolitis and pneumonia, and can lead to long-term complication for lung health. And it is estimated now that 1 in every 28 deaths before 6 months of age is globally due to RSV. Next, please. So RSV is one of the leader causes of pneumonia, and it causes still 40% of severe pneumonia cases before the first year, at the end of, before 12 months of age. Next, please. So I'm trying to go a little bit fast in order to focus more on the region. So there is a very important work published in 2022 on the Lancet, which is about the update and of the annual RSV burden estimates. And according to this data, in 2019, RSV was responsible for 33 million episodes of lower respiratory infection, 3.6 million hospitalization, and 100,000 deaths. And as you can see, the most important proportion of this is happening actually in the first 6 months of age. Next, please. Although RSV affects children worldwide, it is not equitable and in its consequences. And as you can see on this graph, over 97% of RSV deaths occur in low and middle income countries. Children in low income countries are less likely to have access to adequate medical care, and so they are far more likely to die from RSV than children in high income countries. And while deaths are rare in high income countries, RSV presents a significant burden on health system, overwhelming pediatric wards in the winter months and leading to a high economic cost as well. Next, please. So to break a little bit more the deaths among children 6 months of age and younger, can we go back, please? Sorry. Just to show, can we go back by one slide? Can we get the previous slide? Yeah, yeah. In this one, it's important. It's a break of the RSV deaths among children, actually 6 months of age and younger, in LCI setting. They are, as you can see, 4 times more likely. No, last, please. The one before, yeah, in this one. So this is on the, as you can see on the right side, actually, mortality is 4 times more in low-income setting than in the hospitals in these countries. Next, please. So yeah. This is a very important project also. Yeah, this is the one. A project published actually in 2024, in fact. And it's about the RSV positivity among children admitted to hospitals with acute respiratory illness. And it looked at the age from 2010 through 2019 in low-income countries only, but by region. And as you can see here, can we go to the next one, please? As you can see here, around 1/4 to 1/3 of all IRA hospital admission among children less of 5 years of age are due to RSV in almost all regions. As you can see, our region is in pink, so we almost 27.5% as the ratio. Next one, please. So if we go now to the next less than 6 months of age. Next, please. So, no, the one before. Yeah. So if we go now to less than 6 months of age, you can see that this proportion is much higher, with almost now 1/3 of and half of all IR hospital admission among children actually less than 6 months is due to RSV. And in our region, it's around 39.6%. Next, please. Now, if you go back to this project published in Lancet actually in 2022 about the global RSV burden. Next one, please. Yeah. So as you can see here, the RSV-associated acute low respiratory infection among infants in the community. If you can see the incidence, actually, it's on the first on the left. I mean, as you can see, 0 to 12 months. I mean, the incidence, except perhaps for Africa and the region of Americas, the other are of a lower incidence. But in our case, which is in dark blue, the incidence is almost 60% تقريبا. But if we try to break down by age, I mean, you can see something, I mean, except perhaps for Africa, where the incidence is much higher in the first 6 months of life than the second. The incidence in IMRO and the incidence as well in Americas seems to be much higher actually during the second 6 months of age. Next, please. So in terms of RSV-associated hospitalization among infants by WHO region, here it's clear that our region seems to be the first, I mean, in terms of incidence, in terms of hospitalization, as you can see, and then it's followed by Americas. And to the contrary, the region that used to have the highest incidence of cases in the community, here it has, which is Africa, has to the lowest one actually when it comes to hospitalization. It means that the kids in Africa, they cannot make it as easy to hospitals than in the other region. Next, please. Now, if we look at the RSV attributable mortality rates among infants by the region, always, I mean, according to the same study published in the Lancet, actually, the global study, the mortality is very, very high, and is the highest in Africa. It's around 1 per 1,000, followed by EBRU and followed by CRO. Next, please. So if you go more in depth in our region and try to look at the studies published in the region, there were a lot of studies actually published, but I'm going here to go through two systematic reviews. First one published on 2020, and it included almost 600 studies identified between 2001 and 2019. But they focused on 83 studies that met the inclusion criteria. And they found an overall prevalence of 24% of respiratory infection for RSV, comparable to the global one, which is 22%. So it's not far from what is reported at the global level. The highest RSV prevalence was reported in Jordan during 2006 and 2007. It was about 64%. The RSV was most prevalent in children who were less than 12 months old and was higher in males. Finally, the highest prevalence was recorded during winter season in all countries except for Pakistan. Next, please. So the next show a little bit all these studies actually, and it shows the rates in each one of the studies. As you can see, the highest one is in Jordan. It's in dark, in black, in 2007, followed by Pakistan in 2012. So these are just to show to you that the different studies and the variability of the incidence rate according to the season, to the country, to the context. Next, please. So the second systematic review was published in 2021 on vaccines by Hassan Beibo, Youssef and colleagues, and their colleagues. It was a review of 1,242 studies published between till September 2018, and they included only 90 studies in their review. They noticed that most of the included studies actually were conducted in subject aged 0 to 18 years, with the majority being children below 3 years of age, while only 2 studies included exclusively adults above 18 years of age. We'll come back to this later. RSV infection rates varied greatly between different studies, as it was for the first systematic review, and ranged between 4% and 82%, while the range was smaller in studies on outpatient subjects. The RSV infection rates were around 19% among subjects admitted with acute respiratory infection, and it goes then to 33% among those that are admitted for a lower respiratory infection, and even to 70% with lower respiratory infection and 30% for bronchiolitis. Next, please. So the same systematic review noted the seasonality, that it's mostly in winter. Admission in intensive care unit ranged between 1% and 1.5%, while the need for mechanical ventilation ranged between 1% and 0.1%. The overall RSV-related mortality rate across all age groups in studies included in the review was 1.9%. So, and this review identifies several limitations in the existing data and then the representation of the adult population. And this review recommended, and authors recommended, that there is really a need for more studies and more evidence on the burden of the disease, in particular in adults, but as well in the pediatric ages. Next, please. So this is just somebody next one, please. Yeah, I mean, these are just to show where the studies were conducted, the number of studies that you can see on the right side, on the left side, the region, and on the right side, the rates that were actually mentioned by these studies. Next, please. So the 2 systematic reviews concluded that there is little data on older adults, so we don't know really a lot about what is happening in older age groups, but we know that there is a transmission of the disease occurring also from this ages group to the pediatric population. We know that, I mean, RSV rates varied by study, and there are huge differences sometimes, and due to the case definition and the settings. There is a clear seasonality in the disease occurrence, so it's winter almost in all the region. The overall prevalence seems to be around 24% of respiratory infection that were recorded as RSV. And the two systematic reviews and almost all the studies concurred on the need for further studies and stronger surveillance, and like what we are seeing now, for example, in Pakistan. Next one, please. Next, please. So the key takeaways on RSV burden is that first, while epidemiologic data about this virus are available globally, data from our region are still scarce. Second, data show that severe RSV LRTI occurs across the globe. It shows that 1/3 to 50% of all hospital admission for LRTI under 6 months of age are likely due to RSV. Over 100,000 deaths occur from RSV each year, half of which occur in infants less 6 months of age. With the clear disproportionate burden, I mean, 97% of the deaths are occurring in low, medium, and medium-income countries. Most of the deaths in lower income settings occur in the community before a child can access supportive care in hospital, in particular in Africa. RSV also causes a huge burden on household income and on the health system, even in the high-income countries. And RSV seasonality differs according to the region and countries, but there is a clear seasonal pattern in winter in our region. Next, please. So next. So in terms of next steps and how can we move ahead, definitely there is a need for more data in our region in order to understand, manage, and prevent RSV, how to manage and understand and prevent RSV infection. We have very little data from surveillance in the region. I'm very glad to see that Pakistan now, I'm going to sort of go perhaps that through this project with WHO, actually, they are working on generating data, which is very, very important for decision making. There will be a need for an effective decision recommendation and making process, and this will need that because of the cost of the vaccine, because of the scarcity of resources in our countries, most of our countries, except perhaps the high-income countries, because as well of the other competing priorities in the region, definitely there is a need actually for strong evidence-based making decisions. So the role of an attack is very, very strong. And perhaps because of the specificity of the vaccine itself, not of the body of the monoclonal antibody, but the vaccine needs to be for the time being given to a pregnant woman. So this is another platform that is already there in several countries. I mean, this pregnant women in almost our countries are very well vaccinated and with tetanus and with some coverage, diphtheria as well, and the vaccination coverage are high. But definitely now to move to and use more this platform, I think we need also to make sure that ARETAG has the capacity actually, or at least has gynecologists, I mean, on board. Also, it's important to continue working on strengthening ARETAG in our region, but also strengthen the relationship and the interaction between ARETAG and Ministry of Health, and making sure that the technical expertise of ARETAG is very well considered by Ministry of Health in vaccine prioritization process. The third point is adequate. We need an adequate delivery platform with antenatal care, and Dr. Muhammad Imran talked about this issue. And as I said, actually, this platform has been used, but also in some other countries more used now, even for the acelerated pertussis. So we need a lot of coordination, collaboration between EPI, between the maternal and immunization health in the countries, to make sure that vaccine is delivered, that information is captured, to make sure that health education is and the vaccine is also given for RSV, for the pregnant woman, etc. Raising awareness and demand is very, very important, and has not only it's not only for pregnant women, but also for healthcare providers. And some countries now are facing problems, I mean, with the general curiosity, in particular for HPV vaccine. So it means that really we need to work more now to bring on board, I mean, and to fight this hesitancy among some of the healthcare providers. Definitely funding is very, very important. Glad to see that Pakistan is going to make it through Gavi, which is really great. Logistics as well are very, very important to coordinate between the antenatal care clinics and the primary health centers and the vaccination pods, and also to coordinate between the public and the private sector. Next one, please. I think with that, next one. Yeah, just to talk about surveillance, some very brief. I'm not going to say a lot. Just to say that there was WHO is also very focusing on the self-assisted country to generate information about RSV using the platform, the influenza platform, the global influenza surveillance and response system. There was phase 1 started a couple of years ago with 14 countries. And objective was to standardize the RSV surveillance and see how much this can be integrated within the GSRS surveillance without adversely affecting the well-established ILI and SARI surveillance system. Next, please. So the major objectives of this first phase was to establish the feasibility of RSV surveillance built on the GISRS, to evaluate the performance of the case definition that was developed by WHO actually for the RSV surveillance, to look better at the RSV seasonality, and also to build evidence that would enable countries to make informed policy decisions around the introduction of RSV preventive products, such as vaccines and monoclonal antibodies. Next, please. The second phase is in process now. More countries have been included now and focusing more on the disease in infancy and young children less than 2 years of age, focusing more on more severe disease require hospitalization, and also including more low-middle income countries like Pakistan and wider geographic representation in the whole WHO region. Next, please. So as you can see on the map, we have next slide, please.
Yeah, we can see the map.
Yeah, this is the map. Yeah. No, sorry, I did not see the map. No, just to say that in the region we have 2 countries that are contributing now, which are Pakistan and Morocco, to the phase 2 of this study. Next, please. I will end with the WHO recommendation, I think, but the recommendation that are included actually, our integration of RSV surveillance with the global influenza program. So the recommendation now is that all countries, we know that all countries are recommended to implement sanitary surveillance for influenza and SARS, but countries also may consider integrating RSV and other respiratory virus surveillance based on national priorities first, objectives and surveillance capacities and available resources as additional component for the expanded GIS. Countries should define and prioritize so countries that would like now to integrate, they have to define and prioritize their primary and secondary objectives for the sanitary surveillance of influenza, SARS-CoV and RSV based on their national priorities and resources. And it is recommended that countries meet their primary objectives before integrating the RSV. So they still need to make sure that the sanitary surveillance for acute respiratory illness is strong, and that the laboratory testing for influenza, SARS-CoV, and in some other countries, RSV is available and will not really be jeopardized by the integration of RSV. So we are expecting to learn from more about Pakistan and Morocco from the region. And next, please. But definitely, there are other countries that are implementing surveillance. I know that Saudi Arabia is doing it. I know that Lebanon is doing it, and with a couple of other countries. These are just some WHO documents, background document for RSV surveillance integration with the GSRS system, and also for the either WHO headquarters or from Europe. Next, please. I think this is my last slide, and thank you very much for your attention.
Thank you, Dr. Azzuddin, for this comprehensive presentation. I think your presentation answered a lot of the questions that are raised in the Q&A section, but I'll try to sort of highlight some of the key queries that have been raised by colleagues who are attending this activity. So I think one of the question is you have basically alluded to the issue of the cost and the impact of this vaccine on the budget of the very limited budget of countries of our region, and we did hear from Dr. Francisco that the cost in PAHO was $49 per vaccine. And there was a question, any knowledge of what is the cost of vaccine in the EMRO region, if you can assist. And also, I hear that Dr. Imran is with us, so we will direct some questions to him as well.
Yeah, thank you very much. Thank you very much. Actually, I don't have really information from the region. What I know is very, very few countries. I think no country has already introduced the vaccine, except perhaps Saudi Arabia in the National Guard clinics, I think. But I don't have really. But I know that from my participation in the global market information advisory group, that the cost of the vaccine, it's around 40 to 60 to 70, according to the country, type of country, according to the supply and forecasting issues, and those that are forecasted through like in PAO, for example, through pooled vaccine procurement system, they will get better prices. Because of that, it's 46. But in the other, I think it's around 70. But just to say something, that it's less expensive than the 3 doses of the new vaccine is actually, definitely. We need just to say this is only 1 dose that will prevent, huge disease burden during the first 6 months of age and important mortality in this very vulnerable period of life of the kids. Over.
Thank you very much. Maybe a question to Dr. Imran. I think there was concerns by some of the people attending the event that maternal vaccination in general in our region is not the greatest. And how do we see, the addition of another vaccine for the mothers during pregnancy, having an impact on compliance? And I know that we've heard from our PAHO colleagues that they have some documents and some training to sort of enhance uptake among mothers who are pregnant. Any comments from your side, Dr. Imran, on how we can improve the uptake of the vaccine among mothers who are pregnant?
Yeah, so thank you, Professor Ziad. This is a very genuine concern, and is raised by the policymakers, especially when you're talking to them in terms of introducing any new vaccine, whether it be a pediatric vaccine or maternal vaccine. And in this, but we can also use introduction of every new vaccine as an opportunity to further strengthen your immunization system. And of course, before going into the introduction, we do our homework in terms of vaccine demand generation and looking at the contextual factors and the barriers and facilitators for these vaccine, and that can guide us in not only increasing of the uptake of the newer vaccines, but also at the same times, which are already part of the country's immunization program. So that's my take on this.
Dr. Ziad, can I add something here?
Please.
Yeah, I'm very optimistic. This is a very, very special vaccine. So this is a vaccine that will be given to a pregnant woman, a lady that spent 9 months just to get this very important present, which is the baby. So I'm sure we need to focus on this issue because I mean, telling a mother, a future mother, that this vaccine will prevent your newborn from being affected by these bronchiolitis, and we know in the region how much concern these outbreaks, these annual outbreaks now are. I mean, are provided in the community. So I think this is a very special vaccine, and I'm strongly confident that they will take it. I mean, this is a different because in this context, a pregnant woman that is going to give birth to a new baby, I mean, she will accept everything for her baby, but perhaps not for her. I mean, even in countries where they can it's not like the influenza, for example. We have seen that we tried to convince mother to take influenza. There are some hesitancy, but I don't think that this will be the same. And this is the example in Argentina, for example. I know that they use a lot this context and the importance of the vaccine for the first months of life of the baby.
I tend to agree with you, Dr. Azzuddin. I don't think there'll be any issue with compliance. I guess some of the attendees are also concerned about the diagnostics. Dr. Amran, I think two key areas. One, are diagnostics available in countries where the vaccine will be applied? Because otherwise, without having a diagnostic, you will not be able to assess the impact of the vaccine and also diagnose cases and be able to intervene very quickly. And then the second question is, are the cost of diagnostic usually included in the overall cost of the campaign of RSV vaccination?
Again, an excellent question. So the availability of the diagnostic facilities in LMICs in countries like Pakistan is limited. When they are available, tests are they're very costly, are not routinely prescribed. So that remains a very valid concern. Of course, NIH Pakistan is doing a sentinel site surveillance across the country on the backbone of the global influenza surveillance system, and hopefully that will generate some of the impact evaluation data, as well as in my presentation I also mentioned that we are gonna be doing a real world effectiveness test negative case control design also to generate some of the evidence in for real world vaccine effectiveness. But I agree that at present the wide scale testing for RSV is not available.
Thank you. And then, question for our chair of the RITAG, Dr. Azzuddin, which is very critical, is the issue of introducing the vaccine in countries of our region. So we have many countries which are going through conflicts and humanitarian crisis. And then, we have some rich countries which will have no problem in introducing the vaccine universally. But we also have some countries that are economically challenged. And the question from some of the audience is, would you suggest introducing the vaccine as phased introduction into the countries, or do you recommend universal introduction in all countries of the region?
In fact, this is a seasonal vaccine. This is a seasonal disease, and actually, there are two attitudes at the global level. There are countries that have introduced the vaccine the whole year around. I mean, for every pregnant woman. There are others that will only target those that are going to deliver through. I mean, the high season, which means that they will spend at least. I mean, they will cover 30% every year. The problem is that it has to be given to every pregnancy. And this is perhaps the limit of this vaccine, actually. In every pregnancy, we have to give one dose to the same lady. I mean, if she is pregnant this year, she will be pregnant next year. She has to get the vaccine as well, because it's not for her. It's for her baby. And perhaps the duration of immunity given by one dose is not long enough to cover the second pregnancy as well. So some countries are considering, for example, let's, instead of, for example, going and saying, okay, I mean, how to do this? I mean, by region, for example, sub-region started in some governorates and other. But most of the countries are going either, if they have the possibility, the capacity to finance the overall pregnant woman during the year. If not, they will just try to cover those that are going to give birth during the high season. So it can be calculated. So it will cost something around 30% of what should cost a full year vaccination campaign. So it's uninterrupted. So it will be through a couple of months, perhaps 4 months. The vaccine will be given 4 months during a year for those that are going to deliver, for example, in our region, in between December and end of February. So it's up to the country to decide. So it's up to the countries according to the capacities and.
Yeah, I'd just like to add to that. I think the one kind of issue or complexity to that is that in many regions the seasonality is also not well established, and in countries in large countries like Pakistan. We have different seasonal patterns in the northern part and the southern part of the country. And for example, in northern part, we would have a clear winter peak, while in the southern part, you see the transmission all year around with a post-monsoon peak as well. So it's from the logistical and pragmatic perspective also, these present challenges, whether you recommend an year-round vaccination or a seasonal vaccination as well. But of course, it's going to be also depend upon the final the cost of the vaccine, and whether the country is getting it through Gavi support, and all those factors will play.
Yeah, just to say that we will be learning. Because of that, surveillance is very, very important. One of the objectives of surveillance is to understand the seasonality. It's very important to drive the program. The other issue as well is that perhaps in countries like Pakistan or countries that do not have enough resources, actually, they can also look at the burden of the disease. Burden will depend in Pakistan from an area to another according to the capacities according to the health system. I mean itself. I mean in terms of and the population itself. I mean in terms to access to care, etc. So they can balance. I mean trying to get the maximum. Reduce the mortality to the maximum possible, addressing, for example, those areas where still a lot of deaths and diseases happening in community without making it to hospitals. Perhaps they can say, okay, this is my priority for the time being to reduce the impact, and then so it's up to the country. But in order to decide, we need surveillance, we need data, we need to understand really what is happening in the country, even in community, not only hospital, but what is happening in the community as well. Thank you.
I cannot agree more. I think if you put you've raised the key points. I think surveillance and documentation is really important for the burden of disease in many of the countries of the region. I think we're coming to the end of the session. I think this has been an extremely useful discussion. I have myself learned quite a bit from listening to the global data, the regional data, and the challenges that we are facing in our region to try to implement some of the strategies recommended by high-income countries, which are probably not applicable to low and middle-income countries, and the countries where there are huge conflicts and humanitarian crisis where food and nutrition is not being made available. Never mind RSV vaccine, which is quite expensive. But I'm quite optimistic that Gavi, with this new agenda, and also hopefully the philanthropists like within Melinda Gates Foundation, trying to sort of secure the vaccine at a lower cost, will make it more available to our children in the region, inshallah. On behalf of all the attendees, I would like to thank our distinguished speakers for taking the time from their very busy schedule and give us this outstanding presentation. And also thanking all the attendees and thanking
Dr.
EMPHNET.
Dr. Ziad, if you allow me 1 minute, I think
تفضل.
just to say that the regional office is working now on the vaccine security in the region and on a pooled vaccine procurement system. And I think this will be a great opportunity for these countries to get the vaccine with an acceptable price.
Inshallah. I'm very optimistic, inshallah. With that, I would also like to thank EMPHNET for organizing this session and for giving me the opportunity to moderate this session. Thank you very much.
Thank you very much. Have a good day.
Thank you. Bye-bye. Thank you.
Bye.
Bye-bye.